roll call or actually use your tablets.
Commissioner Marecki. Commissioner Baidoon has requested an excuse. Commissioner Anderson has requested an excuse. Commissioner Killeen. Chair Baker McCormick.
Here.
You have a quorum present.
Next item.
B, Chairwoman's remarks.
I have none today. Next item.
C, approval of the February 21st, 2023 meeting minutes.
Vote.
Motion carried.
Next item.
D, unfinished business. There is none listed.
Next item.
Item 1, under new business, requesting commission approval of the appointment of Harold Nimmo to the position of Deputy Director for the Health, Human, and Veteran Services Department.
Hello.
Madam Chair, Dr. Abdullah, Director of Health, Human, and Veteran Services. I have the distinct honor and privilege today on behalf of Executive Evans and our administration to formally nominate Ms. Harold Nimmo to the role of Deputy Director of Health, Human, and Veteran Services, as well as Wayne County's inaugural Chief Equity Officer. She is a daughter of Wayne County and a dedicated servant of the public and the public's health. She comes to us from Authority Health, where she is currently the Director of Programs and Quality. And before her time at Authority Health, they enticed her away. She served Wayne County as Chief Operating Officer for the department. If confirmed, this would not just be the second time that Ms. Nimmo would serve Wayne County's broader public health, but also the second time we'd get the opportunity to work together. I had the privilege of hiring her at the City of Detroit to lead all of our children's programming. That included everything from lead to maternal and child health, and her leadership, her passion for this work, and her strategic thinking, I think greatly benefited the 650,000 people who live in the city. She's an expert in quality and strategy and program management. She's got over 20 years of public health experience. And I know that she's going to bring both that expertise and her own passion, focus, and history in Wayne County to this work every single day. I'm really excited to get the opportunity to work alongside her again. I know that she's exactly the caliber of talent that we're hoping to attract to work here on behalf of our 1.2 million residents in public health, 1.8 million that we serve across human and veteran services. And so I want to leave it to Ms. Nimmo to say a few words on her own behalf.
Thank you.
Thank you, Dr. El-Sayed. Good afternoon, HHS Chairwoman Baker McCormick, Co-Chair Killeen, and the members of HHS Committee. I'm honored and excited to appear before you for this appointment review for the Deputy Director and Chief Health Equity Officer position for the Department of HHVS. I want to thank the County Executive, Warren C. Evans, and Deputy County Executive, Assad Turfy, for giving me the opportunity to serve. Chief Operating Officer, Janelle Allen, for supporting the Department of HHVS, and Dr. Abdullah El-Sayed, the now Director of HHVS, for selecting me for this role. Wayne County served as my home and provided a place of refuge since the age of 10 when I arrived here to live with my aunt after fleeing a devastating civil war in Liberia, West Africa. My family, community, church, education, and public health systems shielded me from the impending trauma beyond my control. At a young age, I remember my aunt receiving calls from the public health nurses to monitor my compliance with TB medication I was prescribed due to potential exposure as a child while living in Liberia. I also remember the then principal at Cass Technical High School, where I attended, writing a letter to the Nigerian government where my mother and 6-year-old sister were refugees. The Nigerian government granted their visas and allowed them to attend my graduation. That was the first time I saw my mother since I left Liberia 7 years prior, and my sister who was born after I left. My experiences in this county has ingrained in me that every individual, every child, every family in our community matters. And the systems that we put in place to support and protect the most vulnerable will yield the greatest return. I'm committed to serving this county because of the care I receive from the people of this county. This commitment led me to contact Dr. El Sayed in 2016 to serve with him at the Detroit Health Department after hearing him on NPR shed light on the importance of investing in upstream interventions to address social determinants for the most vulnerable in our communities. He hired me, and I served as the Director of Healthier Childhoods, where I led the WIC, led prevention, immunization, children's special health care services, and vision and hearing programs, some of the same programs that supported me as a child. With my training in epidemiology, maternal and child health, and program evaluation, Dr. El Sayed and I built some of the most effective programs using community and stakeholder input and data-driven processes that were accountable, collaborative, and transparent. One of those models was how to manage many lead cases with limited public health capacity. As a team, we provided free glasses to children and built a robust interagency data system that streamlined workflow to improve lead poisoning activities, prevention activities. My career experiences also include strategic planning, policy and business development, program design, and research. I have worked in maternal and child health, chronic and infectious diseases, environmental health, healthcare quality and service delivery, behavioral and mental health at the local, state, and national levels. Most recently at Authority Health, I worked to expand the clinical team to include additional community health workers to support patient care management and led the effort to apply for funding to stand up the first elementary school-based health center in Southfield, Michigan. I want to thank Ms. Loretta V. Bush, President and CEO of Authority Health, for her courageous leadership and guidance during my time there as Director of Program and Quality. With the support of my family, I am excited to return to the county as Deputy Director and Chief Health Equity Officer. This position will allow me to utilize all my previous experiences. With your approval of this appointment, I stand ready to work with the team to accomplish the mission of the county. Thank you.
Thank you. Any commissioners like to speak? Commissioner Colleen, Vice Chair.
Thank you, Madam. Thought that was the chair. Okay, it's good to see you again.
To you.
So this is a new title, Chief Equity Officer. How do you interpret that?
Well, I interpret it as, well, as an epidemiologist, I've done this work throughout my career, looking at patterns, trends, differences within populations. So basically working with the community, stakeholders to profile and identify what are those excess differences within our community, putting a plan together and working together to move those forward. Not only looking at outcomes, but most importantly, looking at upstream issues, upstream determinants of health that will change the trajectory of health throughout the lifespan. So it's a comprehensive process where we've already been doing this work, but now we're going to be intentional about integrating it throughout the department, throughout internally, as well as in public health, as well as policy as well.
I'm delighted to hear you use the terminology of social determinants of health. And we have other equity issues out there, and I know something like social determinants, that wasn't really much talked about in the public arena 10 years ago that I'm familiar with, 12 years ago. But it's becoming more and more ingrained into how we deliver public health. So we're going to be going, we're going to be looking at the numbers in terms of our citizens and where certain conditions are higher than other places, you know, as we run down all of the obesity and heart, blood sugar, all of that. So we're going to be looking for more equity across the board with all of our citizens in terms of their health care.
Has to be a systematic approach. So with everything, we want to first do an assessment of what are the challenges in addition to what are our assets, because we can build upon the asset as well and to leverage what is within our communities. So historically, we will profile and identify what are those priorities, what are the greatest needs within the community, given the resources that we have, given the will, the political will, the severity of the issue. Take the feedback and input, looking at the data as well, and identifying what are those wins that we can experience within a short term. And then those systems change that are oftentimes complex, that we need to take time to work collaboratively across various systems to move along.
Commissioner, I really appreciate the line of questioning. You and I have shared several conversations, both in this venue and outside, about the conversation that needs to be had at the department level around centering equity in what we do. And in thinking about this role, there's a reason that we united the deputy director and the chief equity officer role. Oftentimes, you'll have a chief equity officer that gets hired into an organization that sort of sits on a pedestal on the side, rather than being empowered within the organization to think about both strategic planning and programmatic activity with equity in mind. And I do want to be clear, oftentimes when we talk about equity, of course, the most glaring form of inequity is racial inequity. But there are so many different kinds of inequity that we have to take on. You think about the kinds of challenges that, yes, rural, and we do have some rural communities in Wayne County, that rural folks who often tend to be white often face. And so as we think about equity, we're taking a comprehensive approach to equity. Yes, taking on racial inequity directly, but also asking what are the other ways in which inequity shows itself, and how do we build programs and strategy along trying to take those on. And so speaking just on behalf of the department and the structure, there's a reason that we wanted to unite the chief equity officer role and the deputy director role to empower the role to be thinking about this as a prime mover in the way that we move forward as a department.
I'm delighted to hear the conversation from both of you. The key phrase here is what resources we have. That definitely is a limiting factor. And so we're going to have to make some choices as we go. And speaking for this chair, political will is here to really address and attack these issues for equity across the board for our citizens. So, Madam Chair, I support this hiring, and looking forward to a lot of good conversation in the future as we make, which will be some difficult choices as we go, given the fact that the resources are limited. So, thank you, Madam Chair.
Thank you, Commissioner Complain. Commissioner Marecki.
Thank you. Thank you, Madam Chair. And welcome, Carolyn. And we've worked with you in the past, and you're great to work with. You have a great resume. And this is somewhat off of what Tim has been talking about. And equity to me means everybody reaches the same equal outcome. And with health, I mean, I'm going to be interested to see how this goes, because how does that work? I mean, I think people get mixed up with equality and equity. They're two different things. So this is, I mean, obviously the decision is made that you're the equity officer. But I am going to be interested in see how this all works, that everybody comes with the same outcome. I mean, how does that work in health?
Speaking,
In anything, actually, but
speaking on behalf of the department, we certainly understand that equality of outcome is nearly impossible to dictate and to achieve. But we do know that some of the inequalities and outcomes that we observe, whether that's in health or in socioeconomic outcomes or you name it, happens to be a function more of opportunities that existed at the front end. And so our goal isn't to create equal outcomes. We know that we cannot do that as a government agency. Our goal is to make sure that the circumstances in which somebody lives and learns and works and prays and plays, that those circumstances don't systematically keep some people behind. And that's a goal we have, whether we're talking about a low income a Black person in a community like Inkster or a low income white person in a community like Lincoln Park. And that commitment to asking what are the things that we can do at the level of the air people breathe or the water they drink or the communities that they walk in or the quality of the schools that they go to or the quality of food that they have access to, that those things are as good as they can be for everybody across the board. And we know we're never going to get to equal, but we do know that there are some things that we can do to systematically empower folks that have been left behind too often. And so the outcomes are going to be what the outcomes get. We'd love to live in a world where the outcomes were more equal, but we need to live in a world where the opportunities are equal.
so how does equality play in this as well?
So equality, right, is a matter of, there's two different ways to think about it. There's empiric equality, which is, as you talked about, equal outcomes, right? And then there's equality in the way that we treat folks, right? And of course, we all would aim to treat everybody equally. Yes, that's of course. But then there's also equality in outcomes, which, again, as I said, we can't control, right? What we can do is make sure that we're offering a set of programs and opportunities and partnerships that assess and address the systematic differences in the place that people start. So if you've got a kid, for example, who starts their life in a place where the air that they breathe gives them asthma, the water that they drink may be laced with lead, and the school that they go to has been systematically underfunded for years, and the board that they look at, they cannot see because they don't necessarily have the glasses they need to see it. We all know that you can't then look at that kid's outcome and say, well, that just happens to be a matter of difference in baseline skill or aptitude. That has a lot to do with our failure as a society to deliver those basic things for that kid. So that's the place we're focused on. We're not focused on equality of outcomes. We know we can't control that, even if we love it that we had a more equal world. What we can control is trying to systematically target those things, those barriers that too many kids in our community, too many adults in our community, too many seniors in our community face every single day, and then ask how do those things map to their health and what can we do about them. We all agree we should have cleaner air. We all agree we should have cleaner water, but we also know that polluted air or polluted water tend to affect some people more than others. And that's what we're talking about when we talk about equity. It's that difference in that baseline firmament that folks live in that we have a responsibility to address.
So you think with the goal of equity, you can still have equality?
The question of equality is a target, right? And whether you hit the target or you don't, that's not something that we can necessarily control. What we can say is, what are the systematic biases that keep a lot of folks from hitting the target? And that's the goal. So we're not trying to create equal outcomes for everyone. That's not the point
Or
here.
equal opportunity.
It's equal
not
opportunities.
necessarily equal outcomes, because that's not going to happen. I
Exactly.
mean, just in life. But as long as people are being treated equally and fairly, then I can see it happen. I just am interested to see how this is all going to play on.
Yeah, I can share a story. Early in my career, I had the opportunity to work at the state level to profile substance abuse issues within the state. And we had to identify the top 3 issues to focus on in the state of Michigan. And we went through data. We looked at the severity of substance abuse issues. We looked at alcohol-related traffic deaths, opioids, and it was challenging because the state of Michigan is extremely diverse. Up north, they were dealing with methamphetamine issues. In Macomb County, opioids. in the city of Detroit, we had alcohol-related traffic deaths, and we had to come and identify those top 3, and it was challenging. So what ended up happening is looking at each community, identifying what are the priorities within that community and what are the differences. Also studying across communities and looking at some protective factors that are within those spaces that we can spread across other communities. That's why the power of collaboration and looking at best practices and being able to, okay, they did that in River Rouge. Maybe looking at the population, we can try this strategy somewhere else. So we really just, it's about resources. It's about looking at the severity of issues, looking at the differences, and then pouring those opportunities that will serve as protective factors that will improve the trajectory of a healthy health outcome. So.
Thank you.
Thank you, Commissioner Marecki. And I too am familiar with Carolyn and the work that you did and was doing with Wayne County. So I look forward to you being our new deputy director, and look forward to working with you in the near future. So you have my support. Mhm. Right. I think that was all of the questions from commissioners, right? All right. So we will now take a vote. Is there a motion and their support? All right, we can vote.
Motion carried.
Thank you. Congratulations. Right, next item, please.
Item 2, forwarding notification of a 180-day emergency procurement report for professional services contract with a 90-day option to renew with New Image Protective Services.
Good afternoon, Madam Chair. Melissa Fernandez, Division Director for Juvenile and Youth Services. This is in response to emergency procurement to provide staff augmentation for our juvenile detention facility. And we were operating under emergency variances due to our staff to resident ratio.
Can you give us just a brief update on what's the situation there and why this is coming to us, I guess, a couple months late? So if you could just give us an update.
Sure. So our staffing ratio has been improving since we've engaged in contracts with New Image. We have been able to onboard over 35 people since December, which has helped again with ratio. However, our census continues to increase, and so remaining in ratio isn't always easy. We're continuing to onboard with county employees and our contracted personnel as well. This was submitted in December with a holiday and with the breaks. There was some lost time there, which is why it's coming so late.
And how much of a, I guess, staffing shortage are we dealing with right now?
Sure. So we still have about 25 vacancies that we're shooting to hire. It is our hope that we can make some of these contractual staff permanent. So we are actually treating this as a recruiting effort in addition to our rigorous recruiting efforts by our county PHR team.
Okay, so you're continuously trying to increase while we have these contractors on board.
That is correct. We have vetting and new hire orientation that happens weekly. So we're running orientation and training on a weekly basis so that we can get up to level.
And as far as the safety of the juveniles as well as the staff, how is that situation?
So when we are able to maintain ratio, we have a better outcome for safety. State ratio requirements are 1 staff per 10 young people. And we are operating under a variance to operate at 1 to 20 because of our staffing constraints, which makes it difficult.
And there was a COVID outbreak, my understanding, back maybe a couple months ago, where I guess some of the inmates were made to be, I guess, put in a cell together, or can you explain what happened there?
Sure. So those were actually two separate issues. So we did have an issue with COVID. Okay. And, it was our priority to isolate and contain the outbreak first and foremost. Of course, it's our intention that all of our kids have everything they need every day while at their facility. We did make some mistakes. We're committed to ensuring that it doesn't happen again. The incident that you're referring to is we had some of our young people in our intake unit. Intake is a place where when we have new admissions, our kids are waiting to be assessed. We do have room in intake to have 2 and 3 youth in one space. It's not a cell, it's a big space for monitoring. As we were trying to isolate some of the young people, we did have to move them to intake, but they were never placed with other young people. Our move to Dickerson has provided us with increased resources when it comes to proximity. So at the old building, we were so spread out, we didn't have the staff, it was difficult to monitor with line of sight. However, we are limited with space at our Dickerson site. So we did use intake to quarantine some of our youth. However, they were not mixed with non-symptomatic youth.
So how many youth do we currently have in?
Today, we have 142 youth, 120 males and 22 female.
And is this an increase, or is this what's the average number?
All right, so we have seen a significant increase over the last year, and we've been running between 140 and 160 at our highest. Prior to this year and prior to my joining the county, JDF was running an average of between 50 and 80 kids. So we've seen a significant increase. 44 kids today are raise the age youth. Now that's a population that used to be absorbed by the jail. And so that's a significant increase, that we've absorbed. We also have 83 kids with us who are pre-adjudicated. They're waiting for court hearings. But we have 60 kids that are post-adjudicated. And what that means is these young people are waiting for placement. They're waiting for secure placement. They might be waiting for tether for a bond or for a violation of probation hearing. The significance to that is that we've seen the state really clamp down with licensing and decrease the number of beds that our young people can go to receive treatment. So at one point we had over 500 beds in the state. Now we have about 150 beds in the state for young people to be placed in for rehabilitation. And so what we're seeing is that the length of stay has significantly increased at JDF from 3 weeks to 6 to 9 months, sometimes longer. Now, detention by licensing definition is a short-term institution for stabilization, 7 to 21 days. You have to have approvals to have a young person there over 30 days. We've seen JDF turn into a long-term institution of a rehabilitation institution. We are not, equipped for that. However, the options to place young people in institutions in the state are dwindling fast. And so kids are languishing in a detention situation when they need intensive treatment services.
And so with that, how are they being educated over this longer period of time and with all of these changes?
And so when I talk about long-term institutions and short-term institutions, licensing has very clear standards on what young people need to receive in those different institutions. And again, because we are licensed as a short-term institution, we provide services for short-term 7 to 21, day care. However, we do have the Capstone Academy, which is a charter school through DPS. In-person learning did resume on January 12th. We did have a lag because capstone is a DPS charter school, and we moved to Hamtramck. And so, in our efforts to move our young people for safety swiftly, that was something that, we did overlook in our efforts to move them quickly. However, DPS and Hamtramck agreed that we could operate, and so we are in person as of January 12th.
So they actually come to the facility and they have a classroom there for the students now.
We have 16
the
teachers
student.
as of today, correct?
And then they teach all of the subjects, math, science.
Yes, they teach the MDE approved subjects,
And do
Spanish.
they have computers, laptops? in
Right
place?
now, they do. The school actually has Chromebooks that they roll in and out.
Okay.
But the young people do not have computers in their rooms.
Thank you. Commissioner Marecki.
My voice is loud. How is it going with the courts with the pre-adjudicated kids? Are they on track with this, or are kids going in person?
No.
They're still not?
No. So kids are still having virtual hearings. That poses some challenges as far as how quickly they can have hearings. We do meet with the Third Circuit Court weekly. We provide length of stay reports to them weekly so that they're monitoring the pre-adjudicated and the post-adjudicated kids, and can prioritize kids that have been there for a long time. Since we've been doing that with our judges and our new presiding judge, Judge Miller, we've seen an increase in kids that are eligible to go home into the community with increased supports. So for example, today we have over 100 kids on tether. This time last year, we had 53 kids. And before that, the year before that, we had 44 kids. So we're seeing some movement. However, as we release kids to have increased community support, we're still getting kids in. So efforts are being made. We're just not really making a dent in our
So
bed utilization.
when are they going back to court? I mean, how long are they going to be?
I do not have an update on that as of yet.
Okay. Seems like a long time to keep going on Zoom with this. All right, thank you.
Commissioner Colleen.
I think I got it. No? Yeah. Well, so I'm going to ask you a few questions just to really understand the situation on the ground. You referenced, well, just as far as staffing level goes, how many total employees do you have for the JDF?
For direct care staff, I believe our number is 65. Total employees, I'd have to get the number for you.
How many does the state think we should have given the ratios?
Well, the state defines ratio as our direct line of sight with direct care staff. So clinicians will not count to ratio. Teachers do not count to ratios.
So how much are we missing our ratios by?
So we're still missing about 25 staff. So we're still about 25% away from meeting our ratio.
And out of the total staff you have right now, how many of those are contract employees? How many of those are county employees?
I believe 30 are contracted employees. So about half are contracted employees.
And will this contract, does this anticipate another 25?
Yes, correct.
They're going to get paid versus a county wage scale?
I do not.
And you mentioned intake too, because we have, I still want to call it the JAC, Assured Family Services. They're doing evaluations of our folks over there?
So the JAC conducts all the evaluations once a young person is adjudicated. When a young person is admitted to JDF within 24 to 48 hours, our clinicians conduct a mental health assessment.
Okay, what's the role of Assured Family Services?
So Assured Family Services, while they're at JDF, they do not have any role inside other than our web unit, our web monitoring, our tether unit monitoring. So they do have some space in JDF, and it's mostly for tether for substance abuse testing. So when a young person comes in intake, they receive substance abuse testing.
Their role also to make recommendations to the court in terms of services and
They do after the assessment and once a youth is adjudicated, correct?
so they do the assess. What do our people do for intake?
Our clinicians. We have a whole, so once the youth is admitted, they have a mental health evaluation with our clinician, and then they have a case manager that explains the court process, explains, what's going to happen next, meets with the family, and our intake department enters in all of the information regarding the court hearing.
Separate from what Assured Family
That is
Services.
correct.
Okay.
Yes.
Because we're backlogged in the courts everywhere. I think we got folks, boy, you talk about being a short-term facility. Yeah, that's what the county jail is too, theoretically. But when people are waiting, what, 2.5 years in custody or on tether for their speedy trial. I've heard that somewhere in America, we get speedy trials. How long are the cases in general or if you want to talk about it in terms of how much different it is from 3 years ago, how long are the courts taking now?
The courts are having hearings daily. However, the dockets rotate every week. So jurists might not have a hearing, might have one hearing every other week. Depends on the docket. Preliminary hearings happen within 24 hours of admission.
But that's also playing into our 7 to 9 month
Correct.
extended stays. My goodness, how many county employees have we been able to bring on in the last couple of years? You're talking about recruiting efforts and.
A couple of years, I would have to look on the past.
I can live with ballpark.
Probably for juvenile detention specialists, 20. I'm comfortable saying 20.
And are we rotating them out the door on the other end or?
We are
leaving?
not. We are not.
Okay, that's good to hear. So wasn't that long ago, we had 20 less county employees over there? Because I do want to get off of this short term, right?
Absolutely.
It's better if they're county employees. I'm going to say having a trained county employee, maybe this isn't the way I mean to sound it, but just for, rather than pulling someone in off the street and saying, here's the job. Because I don't know if these folks have experience working in facilities such as this that we're hiring.
Yes, that's what has facilitated some of the onboarding, is that they've had the background checks completed and vetted to work in a CCI, in a child caring institution.
So some will have a background in this.
Correct.
The matter of secure placement. You referenced that the state has changed its standards for licensing institutions. And we know in so many ways, mental health here in juvenile, having the option of a secure facility rather than this institution. How does the county get more beds? Is that totally a state decision? What's to get more secure facilities, to have more places for these youth in the county or out of the county?
Yes.
What's the role of the county in securing more beds?
So the county has been engaged in conversations and meetings with the state of Michigan, and I will have Brian Manning talk a little bit more about those conversations. However, it's getting providers to want to open up more beds. As you talked about, licensing really is striking down regarding what we can and cannot do with institutions, and the risk is just too high for folks to continue to want to do that. And the folks that did exist their license has been revoked because of violating standards. And so there really hasn't been a balance with shutting down institutions and ensuring that the beds still exist for the kids that are in placement. There are beds that are available. However, due to staffing constraints at other institutions, we cannot fill them. So the other institutions have the luxury of stopping admissions. We don't at JDF.
You're saying 150 beds statewide?
Correct.
But it is the state's response. I mean, we can have conversations with the state. Hey, we need more, we need this, we need that, but it's really up to the state to take an action, correct?
Correct.
Is it a matter of, because this is serious business.
Absolutely.
This is extraordinarily serious business, especially with young people. What can we do as a county? I mean, and how many beds are out there where the state that are not being used? As you were just referencing, other folks that run these have their own staffing shortages. So is there another 60, 80 beds out there that if they had enough staffing?
Yes. So currently we're working with Spectrum Human Services in Highland Park. Spectrum has 186 beds across the campus and currently only are operating 50 because they can't staff the rest. So essentially we have vacant beds to move kids in. We are working with the state in order to receive some financial assistance so that they can address their staffing issue. And we are also working with our CMOs in efforts to provide programming so that we can get in and open up those 86 beds that are closed due to lack of staff.
So they're looking at ratios too, the state. And is it the state that has to fund this? Fund these-
Childcare, right. So it would be childcare.
Not us.
Right.
It'd be nice to get those beds open, even if we could. And the other thing is, are they using this firm too? Are we competing with these folks to hire the people that this contract is looking to hire?
They're not using, they're using their own HR efforts for hiring.
They're doing their own. Okay,
Right.
so we're not in competition there. It's just, okay, yeah, we need to do this. But the situation just is not good. And it goes back to the funding and the commitment in state budgets, in our budget. I hate the piecemeal, you know, because I think that shows up in the services that we're able to deliver then, especially for this population, these young folks. All right, I've run out of questions. Thank you, Madam Chair. Thank you very much for the answers.
Thank you, Commissioner Kling. So what is the solution?
So,
Do we have any idea what that looks like?
you know, we really have a systemic issue. We've had a collapse of the juvenile justice system in
Yeah.
the state and in other states as well. Locally, as I said earlier, we're meeting with our jurists. We're reassessing and reevaluating cases. We're trying to do more community work on the front end instead of having them sitting and languishing in long-term institutions waiting for therapeutic care. And I think we need to be more of a voice in our efforts with Lansing and holding them accountable as well.
And Brian, did you want to comment on our, I guess, negotiation with the state on what's happening here?
Assistant County Exec, CEO's office. It's all downhill from here. It's been Janelle Allen and I are meeting weekly with kind of senior staff from the governor's office right now. Pretty much just to get the resources of the state marshaled and kind of in alignment in an effort to deal with this. Kind of in three phases. There's an immediate phase. We have an emergency here locally with an overcrowding of our own child caring institution, the juvenile detention facility. Luckily, the Children's Services Administration of DHHS and the county kind of identified the same near-term issue, and that is basically getting capacity back online at Spectrum Highland Park campus. To that end, the Children's Services Administration at DHHS they've granted $3 million directly to Spectrum for purposes of pay increases, retention bonuses, onboarding costs to basically scale up. Objective here is a 40-bed increase at the Spectrum campus within 90 days. That's aggressive. It takes 30 days just to train and prepare staff for onboarding. So, you know, it's a great commitment. It's the right goal, you know, and we're going to try to keep fidelity with it as much as possible. We're meeting weekly with kind of this leadership team, and you know, Melissa and I right now are working also with actors here on the private, you know, agency side with Spectrum. A couple of the CMOs as well are kind of trying to do some innovation here as well. Southeast Michigan are just beyond usable life, whether Detroit Behavioral Institute, the old Don Bosco program. Wolverine had a few programs on the Lower East Side as well, which, you know, served these kids for decades. But again, we foreseeably need new beds that, you know, the state will procure, they'll set a rate. And once there's a rate for the use of those programs, the county and the state will bear that cost equally, like any child care fund. In the fullness of time, we need kind of the state's efforts aligned around licensing and, you know, maintaining a network of services. Both the Division of Child Welfare Licensing and the Juvenile Justice Division of DHHS report through a single state agency, the Children's Services Administration, and what one giveth, right now the other taketh away. We've had a lot of licensing actions against the agencies, and any given action, of course, you know, we need licensing there to oversee and ensure that there's safety and that the conditions are appropriate for kids. Ended consequence of kind of the more aggressive and active enforcement through the years, a lot of private agencies have exited this line of business. They can't get insured. It's very hard to attract staff. You know, candidly, I mean, there's been a health concern that's kind of spiked up on top of that during COVID and any kind of this. Medicines, you know, among employees who are very cautious or concerned for their own safety and well-being, and also the conditions in the macro economy too. You've got attractive jobs out there, you know, available to people in the field, within the field, but not in this part of the field, or completely out of the field, which is, you know, a longer term discussion with the state. The good news is, at least in the near term, we have agreement on this critical piece with Spectrum. That will necessitate an amendment with our contract with Spectrum. So foresee within the next several cycles, we'll see an amendment, you know, proposed by the alignment with the state's objective of these additional 40 beds. So that's more than you wanted to hear, probably. But I do. You know, this has been a 16-month engagement with the state. Right now, I would say we're getting a tremendous amount of responsiveness. I'm getting calls. I mean, we're having workout meetings on individual kids in certain cases. So, I mean, it's hopeful, but we need to make some material progress on the Spectrum initiative. So.
Well, thank you. I think it was sufficient information that you gave us, because we have been asking for what's been going on. So thank you so much, the both of you, for coming today. And there is a motion. Oh, did you have another question? I'm sorry. Okay.
I'm going to kind of leave that go now, but
last point, these 40 incremental beds going into the Spectrum complex are for county kids. Wayne County kids. Yes. So in the fullness of time, and what I say by intermediate, I'm kind of thinking 6 months to 2 years as an intermediate time frame. We need to build new beds, and that's just something. Probably falls toward long term if we're talking about federal funding, but I mean, not directly, no, but potentially indirectly by doing some things with the state, maybe. But I feel it's theoretical enough that I hate to even, make any kind of specific commitment.
We can't hear Commissioner Colleen.
Did I do this?
There it is.
Ah.
Thank you, Commissioner.
Yeah, thank you. I could use a red light on my, so have we talked to the Wayne County delegation? Because we're gonna have to appropriate some money for this at some point, and the legislature, I would think, would have to do it. So, what are the key committees? You don't have to do this now, of people we should be talking to and in the legislature and raising more awareness there.
We agree.
Pardon me?
We agree that it needs
Yeah.
to be done. This is going
So
to
have we
come by
talked to
way
like
of
the Wayne County caucus, or are we in discussions with key members of the legislature, the speaker?
variety of county needs, and of course, this one is at the top of the list.
Yeah, but I'm just talking about this one.
This is going to come by way of the DHHS appropriation request. They're the ones budgeting for this, so it's one of these educating, the key legislators who are going to see this, on the policy side. What numbers do you need to see going up? And they're all going to be going up. Nothing's gonna be going down in this area.
I would think the voice of the Wayne County Commission with the electeds up there could be helpful as well too. Because that long-term question, I hate having short-term patches and patching more and coming back in 2 years. Well, we have to patch it again. We haven't dealt with the long-term issue. So, okay, well, that gives me a picture. Thank you, Madam Chair, kind of what is and what isn't in Lansing these days. Okay.
Thank you, Commissioner. Thank you again for coming today. Right, and there has been a motion and support on this item. Right, this is to receive and file, yes. We can vote.
Motion carried.
Right, next item, please.
Moving to the addenda, item 3, requesting commission approval of the fiscal year 2022 through 2023 subrecipient agreement with Wayne County Healthy Communities.
Good afternoon, through the chair, Ebony McCann, Health, Human Veteran Services, Adult Community Corrections Administrator. The department is requesting permission to enter into a one-year agreement with Wayne County Healthy Communities to provide a trauma-informed care program for our women probationers. Wayne County Healthy Communities identified Black Family Development and will subcontract with Black Family Development to provide these services. As a result, Black Family Development has developed a robust, comprehensive plan for trauma to address the needs of our female probationers. The program will take place in the community at Black Family Development's Samaritan Center location, which is located at 5500 Connor Street on the east side of Detroit. If the probationer is unavailable to meet at that location, they may implement virtual and/or individual sessions. The contract shall not exceed $150,000 with $15,000 administrative costs to Wayne County Healthy Communities, as they will be serving as the conduit for treatment and services.
Thank you. Any questions from commissioners? Commissioner Colleen, Vice Chair.
To testing, there we
Yes,
go.
we hear you.
How many individuals are we going to be able to serve here? Or are we going to be able to serve the need that we have through this contract? Or are we not going to be able to reach everybody?
So the projected number of participants, which was identified in the 2023 application, was 60. I do anticipate that we would meet or exceed that number as MDOC is waiting for this program to get up and running. So there is a significant need for trauma-informed care for our female probationers. And so we have essentially a waiting list for the program to start.
Got a need with all our probation. So is this, this is just an ongoing thing then? It'll be the professionals at Black Family dealing with these individuals to say, we need to see you more, or we evaluate someone and say, okay, we don't need to see you anymore. How's that going?
Like most behavioral health programs, the participants, when they are admitted to the program, will meet with the therapist. The therapist will then identify their need or modality for treatment, and they will assess each individual on a as needed case scenario, and they will cater and cultivate their treatment program to address their specific needs.
Fantastic. Thank you. Thank you, Madam Chair.
Thank you, Commissioner. Any other questions? All right, thank you.
Thank you.
And there is a motion, and it is their support for approval. We can all vote.
Motion carried.
Next item.
Item 4, discussion by the Department of Health, Human and Veteran Services on upcoming outreach events.
Hello?
Yes.
Testing,
I understand, Commissioner Colleen, this does need to line up. Natalie Dean Wood, Director of the Public Health Division, here to speak to you on behalf of the upcoming events that we have scheduled in the Health Department. Just to let you know, this is a living document, which means as new events come on, we will keep you apprised of the things that are coming on. One of the things we're thinking about as we move into the next year under our new leadership is engaging and enhancing our outreach activities, meaning putting more focus into it, being more proactive and searching out opportunities versus being reactive. One of the elements of this, as Dr. El Sayed spoke about, is the funding mechanism that we need to enhance our outreach and activities for the Public Health Department. The items that are listed on the sheets today that were provided to you prior to the meeting are the things we have scheduled thus far on the calendar. And as I mentioned earlier, this is a living document, so there may be additional things added. And as we add things, we will make sure that we update the committee.
Okay, any questions from commissioners? So I am just so glad to see this outreach effort in the community. So I just want to commend you on that. And thank you so much. Oh, I'm sorry. Before you leave, Commissioner Vice Chair Colleen had a
Okay,
question.
I'm not gonna, oh, that's on, and I'm not gonna hit the request to speak. What's the nurses outreach thing? Everybody needs nurses. Is that, are we looking to, what are we looking to do with the nurses program awareness event?
That is actually an event that we've been asked to sit on from our safe sleep program. So the safe sleep program, making sure you put babies on their
It's
back.
specific to that program.
Yes, that program in particular is being a member and being a part of the nurses program. It's not our nurses program.
You have other priorities that are not up here?
Our priorities,
outreach.
as I mentioned, is just general outreach in regards to enhancing our outreach, supporting more outreach activities and being proactive about outreach.
But you have to pick topics at some point
Yes.
that we're reaching out on. So I'm wondering what the process is for what are the outreach efforts that are front and center on our burner.
So, Madam Chair, Dr. Abdullah Sayed, Director, HHVS. So I really appreciate the line of questioning. We recognize that this is a relatively thin list and outreach is going to be a big priority. I see that on two tracks. The first is there are a lot of programs that we offer that we'd like to get out to the community. And so we're looking forward to partnering with commissioners in their districts to get the word out. But the second piece is also partnering toward outreach on a set of new projects that we'll be talking about hopefully very soon that will plug some of the gaps that we have in our current programming. And that includes everything from mental health and substance use to air pollution to safe birthing. And we will, with all the projects that we hope to be able to come together and construct, that we will be able to work together toward getting those out to the community as well. So we recognize that, if you're running a program and you're running it in the dark and nobody sees it, you're not maximizing the output there. And so as we construct, as we build, as we think about, top to bottom, how we operate programs, building a outreach plan, an advertising plan into that is going to be a priority for us. So we look forward to, as Division Director Dean noted, to expanding upon this living document that we offer here today.
Because, we know from experience, people that need outreach are the folks that are hardest to find for so many reasons, right? Whether they have a state ID or not, or how much they're really interacting with the world. And that's one of the reasons why they need the effort, is because they're kind of not to be found. And so that's the population. And going back to things like social equity and all of those kind of things, we have too many people that are just kind of off the radar. So I'm not going to pursue it further today, but the more we can have a strategy to outreach to those folks, I think is probably the most beneficial to our county and our society, and not just leave folks out there hanging. So, okay, well, again, I'm delighted to hear the conversation and the line of thinking that we're doing. I know we have new leadership, so that's going to take a little time for a lot of that to take hold, but definitely looking forward to the ongoing conversation about this. Thanks, Madam Chair.
Now I'm off. Okay. Thank you, Commissioner Colleen. We have our chair of the commission. Chair Bell is on the Zoom. Good afternoon.
Good afternoon. Thank you, Madam Chair. I just wanted to piggyback really quick on the upcoming outreach events. I think it's so very important that we're apprised of those. So I'm so very happy to see this. I want to thank Dr. El Asayed and Ms. Dean for providing this information. And also want to throw in there, and I've talked to the doctor about this, and we've talked about it as a commission, maternal mortality as well. We just saw a powerful film on that over the weekend, and we know that maternal mortality, especially in the African-American community, is an issue. So just making sure that that's on the list as well. And I've talked to the doctor about it, and we're going to have further conversations. But I'm just so delighted to see this list here, and I'm getting out to the public is so very important with these outreach efforts. So thank you both for presenting that. And I look forward to updates on this monthly. Thank you.
Yes, ma'am. Thank you.
Thank you, Commissioner Chair Bell. Yes, and I too, when I saw the list, I'm just elated that you're being proactive and getting out in the community and reaching out to our constituency. So thank you so much for that. Thank you. All right, next item. Actually, we need to, there was a motion and support? Nope,
Another
this is
discussion item.
discussion items. So we already had discussion on the juvenile detention center. I think we had thorough discussion already on that. I don't know if there's any other questions from commissioners on no? All right, next item.
F, such other matters as may be properly submitted before the committee.
There are no such other matters. Next item.
Public comments.
Anyone here in the audience today? Would you like to make a comment? Anyone? Anyone on Zoom? Or any emails?
There are no emails.
Is someone speaking? Oh, I'm sorry. So there are no comments online?
There are no hands raised on Zoom.
All right. Next item.
Adjournment.
So moved.